Hello, my name is Dr. Joshua Richter. I'm an associate professor of medicine at the Tisch Cancer Institute, Icahn School of Medicine at Mount Sinai, and the director of myeloma at the Blavatnik Family Chelsea Medical Center at Mount Sinai. Today, I'm going to review the data that we presented at the 2022 European Hematology Association meeting, early, deep, and durable responses and low rates of cytokine release syndrome with REGN5458, a BCMAxCD3 bispecific antibody in a phase 1/2 first-in-human study in patients with relapsed and refractory multiple myeloma. I have some disclosures. So, Regeneron 5458 is a very exciting new molecule in myeloma. It is a BCMA-CD3 bispecific, so it engages both BCMA, which is expressed on the plasma cells, as well as CD3 positive T cells to induce cytotoxicity and kill those malignant myeloma cells. We know from a variety of studies that patients who are refractory to multiple classes of agents, refractory to drugs like IMiDs, so Revlimid, refractory to PIs like bortezomib, and monoclonal antibodies like daratumumab, have fewer and fewer options and unfortunately generally have poor outcomes with progression-free survivals ranging in the 3 to 5 month range and overall survivals of around 6 to 15 months. So here we report our data on the Regeneron 5458 molecule, which is showing a lot of promise in this arena. So the study design here is presented. It's a phase 1 study, so the primary endpoint is things like safety. However, we were looking for identifying the recommended phase 2 dosing, as well as to evaluate things like overall response rate, duration of response, progression-free survival, and of course, overall survival. Patients who were eligible for the study had to be relapsed and refractory and exposed to at least 3 lines of therapy, including an IMiD, a PI, and a CD38 monoclonal antibody. The dose levels are presented here, and essentially because this drug induces an immune response, as we approach with many different bispecifics, we use a step-up dosing strategy. So week 1, you get a low dose of the drug. A week later on week 2, you get a slightly higher dose. And starting at week 3, you get your full dose of the drug, and you maintain that weekly dose up to week 16, after which you get the drug every 2 weeks, and you stay on it until progression or intolerance. These are the baseline characteristics of our patients: an average age of 64, with 21% of patients being over the age of 75. We noted that about 64% of patients had prior stem cell transplant. These patients had an average of 5 lines of prior therapy, ranging from 2 to 17. 38% were pentarefractory, and 90% were refractory to their last line of therapy. In terms of safety, overall, the maximum tolerated dose of the drug was not yet reached. We did see 2 DLTs at the dose level 4 and dose level 6 group, but still the maximum tolerated dose had not yet been reached. Here are the main safety adverse events, and the majority of these are grade 1 and grade 2 and hematologic in nature. Some of the non-hematologic AEs that we saw were things like pneumonias and upper respiratory tract infection. When it comes to any type of T-cell engager, we focus on 2 big adverse events of special interest. One is ICONS, which is the immune effector cell neurotoxicity syndrome. And here we saw a few grade 2 events, but no grade 3 or higher ICONS, which is very encouraging. When it comes to cytokine release syndrome, which is the real big one, the average rates were about 38%. The median time to the first symptoms of CRS was about 10.1 hours. And if we look here at the different dosing cohorts, so from the low doses of 3 to 12 milligrams all the way up to the 2 to 800 milligram dosings, we really didn't see significant differences in CRS rates or grades between the different dosing cohorts. Now, again, the CRS was all grade 1 and 2. We saw no grade 3 or higher CRS. Also, kind of an important thing is that there was no relationship not only between CRS and dose level, but there was no relationship between CRS and response. And we're always trying to figure out who is going to respond. And we like to think that some CRS means that the T cells are getting activated and that will lead to response. But there was no clear correlation in this study. As far as efficacy, across all the dosing cohorts, if you put all the patients together, the overall response rate was 51%. However, if you focus on the higher doses, the doses that are really going to be used in future clinical practice, we saw an overall response rate of 75%, with 58% of patients achieving a VGPR or better. Among the responders, we saw an 86% rate of VGPR or better and a 43% rate of CR or better. Now, of the patients that we had MRD analysis, which was about 10 patients, 4 of them had achieved MRD negativity by next generation flow cytometry at a rate of 10 to the minus 5. Here in the swimmers plot, we see that there are many people who are having not only deep but durable responses. The median time to response is less than 1 month, and 70% of responses occur within the first 2 months. The estimated duration of response has not yet been reached, and we have patients who have been on this therapy now for over 19 months. So putting it all together, we see that this compound, when tested in patients who have an average of 5 lines of prior therapy, is pretty efficacious across all dosing levels, 51% response rate, but from the 2 to 800 milligram dosing levels, 75% overall response rate, with quite a number of these patients achieving deep responses like VGPR, CR, and even MRD negativity. The median duration of response has not yet been reached. And what's also important is the safety, in that we saw no grade 3 or higher icons or CRS. And across the board, although all the CRS was grade 1 and 2, we saw an average rate of around 38%. Part of this may be related to the double step-up dosing. So overall, we are extremely encouraged not only by the efficacy, but by the toxicity profile of this agent. And there are ongoing studies to optimize dose, optimize combinations with other myeloma therapies, and really looking forward to seeing how this data pans out. And with that, I would thank you very much for listening.